What a sweet sound that can be, especially after 9 brutal rounds of chemo. But ringing the bell isn't always the end of cancer treatment. Good morning. It's Monday, March 6th. I'm Alexis Del Cid in for Jessica Lovell. Welcome to the Morning Medical Update. Today you'll meet a woman who knew something was wrong inside her. It still took months to find out she had colorectal cancer. We're going to learn the early warning signs that you need to pay attention to. You'll hear the ups and downs of treatment, and you'll see the awesome support from friends and neighbors and what that looks like. If you have questions about colorectal cancer or what it's like going through treatment, send them in. We love answering your questions, and our guest today can help answer them. The links are right there on your screen. You can use Facebook, YouTube, Twitter, or email. Some new numbers from the American Cancer Society show colorectal cancer rates are dropping for a large section of the population, but not for people younger than 50. Take a look at this 20-year chart. It shows a serious drop in cases for people ages 65 and older. But as cases dropped for them, cases crept up for adults under the age of 50. Today, we're joined by Tiffany Kessler, a colorectal cancer survivor who was diagnosed at the age of 40. Thank you for being so open and so willing to share your story with us, Tiffany. And we also have your doctors. Dr. Raed Al-Rajabi is a medical oncologist here at the University of Kansas Cancer Center who oversaw Tiffany's treatment plan. And the treatment included surgery done by Dr. John Ashcraft, a colon and rectal surgeon here at the University of Kansas Health System. So thank you all for joining us. Tiffany, I would love it if you could take us back to the first signs where you knew something was wrong. What were your first symptoms?
Well, honestly, my first symptoms went back to the beginning of COVID, so spring of 2020. And the first symptom, I guess, was just like a lot of fatigue. I was just more tired than usual, but I had 3 kids, so kind of just dismissed it as just being run down from that. And then after a while, just started feeling very full, very bloated after I ate. And so honestly, the first symptoms were just very vague, like digestive issues and some fatigue.
Boy, that's tough because so many people watching have stuff like that. They're tired, they feel run down, maybe they feel bloated. I mean, you just described like half the women watching, right? All the moms. So how long did it take until you finally learned that these problems were cancer?
Well, I had a couple of trips to my private my PC doctor, and they did some allergy testing at first and made some diet changes. That made a little bit of difference. Went back to the doctor. They did an ultrasound. Everything with that came back normal. Came back a few months later, around the spring, probably summer of 2021, and had some blood off and on in my stool. And at that point, they decided to check out that and do some blood cultures of my stool. And since that came back looking fine, they said I should probably go to a GI doctor. And at that point, that's when the colonoscopy was ordered. So November 2nd of 2021, when they did the colonoscopy, they found the tumor, and that's when I was diagnosed.
So Dr. Al-Rajabi, what are the red flag symptoms then that people need to know about? Because Tiffany was having these vague symptoms. Are there any symptoms that, short of blood in the stool, that should have you immediately calling your doctor and making an appointment for a colonoscopy?
So like we mentioned, I think, these vague symptoms are usually temporary, and the key is persistence. If they persist more than 2 weeks, then it's probably not something related to your diet. So that's when we really want to investigate this further. But other symptoms that you could experience include, the fatigue that we talked about, weight loss, crampy abdominal pains, blood in the stool. Of course, we talked about that. But those are the symptoms. If they persist and they're not normal for you, I think you should definitely seek medical attention.
So Tiffany, how old were you when you were diagnosed?
It was less than 2 months after my 40th birthday.
Oh my gosh, so young. So when it comes to younger patients under the age of 50 being diagnosed with colorectal cancer. I want to ask our doctors, Dr. Ashcraft, are you personally treating more and more patients under the age of 50?
We are. We see more and more and more patients that are under 50. Dr. Awarjabi and myself and the team at the Cancer Center, we see these in a multidisciplinary standpoint. And it used to be you would see all patients, they were 60, 70 years old, but now it's not uncommon to see 30 and 40-year-olds. And we don't know why. We have no idea why the rate is increasing, why that graph you showed earlier is going up. But there's something, whether it be environmental, microbiologic in terms of the microbiome, toxins, we're not sure what it is. Hopefully research will bore that out for us soon, but we do see that rise, and we're seeing it at the Cancer Center.
And Dr. Awarjabi, was there a point, and can you pinpoint a point where you finally started to be alarmed by this, where you're thinking, what is going on?
We've really been seeing this dramatic trend for many years now, and I think people below the age of 50 hit a new landmark recently that their rates have increased by 50% from historic in 1960s range or 1970s range. So we're going to see more and more of this, and the expected rise may go up to 140% by the year 2030.
2030 is really right around the corner. That's not far away. Are there any working theories? I know nothing concrete, but when you say biomes, what would that be?
So every human being has their own host of bacteria within them, or their own grouping of bacteria, and they're the host. And we call it the microbiome. And we see when we study the microbiome of patients who have cancer, the bacteria numbers and the ratios of those bacteria are different for cancer patients than they are for non-cancer patients. And so there's a theory that maybe the microbiome and the environment and within us has changed, and that may be leading to it. Probably the most pervasive discussion that I've heard, Raed, and it has been that it's about the processed foods and the amount of processed foods that we're eating. Okay. We've eaten more than our grandparents and our parents, and our kids will eat more than us, and so we think that it may be something related to processed foods, but the true answer is when you see it in these large populations like this, it takes a long time for us to tease out the specifics, and it's probably going to take us several years to get this figured out.
Tiffany, I want to talk to you a little bit about your treatment, and thank you for being so open about this. This is going to help so many people. This began rather quickly after a rectal tumor was discovered, within 2 weeks, is that correct?
Yes, I had my colonoscopy, like I said, on November 2nd, and by, a week later, I was getting CTs and MRIs, and 2 weeks after my colonoscopy, I was in the office with Dr. Awarjabi and Dr. Ashcraft discussing treatment plan. Less than a week after that, I had my first round of chemo. So it was very quick. It was a whirlwind. It was scary. It was, but I was thankful. It was the waiting in between that was almost the scariest. So I was kind of almost excited to just get ready and get started with treatment.
Now, is that typical to move that quickly, Dr. Ashcraft?
We try to. The second we get our navigators, who are a great group of nurses that work in the Cancer Center, they're amazing. They will gather all the data for our patients and funnel them to us so that we can see these patients. Once we get the navigators connected and they get all the data, we get the patients in. The good thing is at the Cancer Center, Dr. Awarjabi and myself, for example, see patients at the exact same time. And so a patient can see me first thing in the morning, or Dr. Awarjabi, and then flip-flop and see the other one an hour or two later. And so that really expedites things. And then we can't forget that we truly do a multidisciplinary approach here. And so we have tumor board every Friday for all of our colon and rectal cancers. And we present patients just like Tiffany. We presented her case actually a couple of times. And that gives us a chance to let everybody weigh in and discuss the multidisciplinary approach that we want to take. And that whole process can happen within a week's time, from seeing a patient presenting on tumor board, getting all the answers. But in the meantime, it's Dr. Awarjabi and his group that are quite integral in the beginnings, because the vast majority of the times right now for rectal cancers, not so much for colon, but for rectal cancers, we start with chemotherapy and radiation first. So it's in their world first.
When it comes to chemo, Tiffany, you've talked about rather openly how tough that was. You went through just a brutal treatment. Look at that picture. You look like you're hanging in there. You're tough. How painful was chemo for you?
Well, I'm not gonna lie. It was brutal. But Dr. Al-Rajabi and Dr. Ashcraft definitely gave me a warning that it was a very strong regimen, that, this was going to be my best chance at a cure, which with, 3 young kids at home was definitely in the forefront of my mind. So, of course, it was what I was going to do. But yes, the side effects, the symptoms, they were intense for sure.
At one point after the first round, you were in the hospital, right?
Yes. So I had my first round, and then about a week later, had a fever, and obviously, they give you a list of things to call if you experience those symptoms. So we called, and they said to go on in, and had colitis and neutropenic fever. So I was there for a few days, and it was very scary. I was, kind of in my head saying, if I can't get through 1 round, how am I going to get through 8 more?
Right.
But yeah.
You did it, and here you are.
Yeah.
You're a force to be reckoned with. I just have a quick follow-up. So were there times when you were in the room with both Dr. Ashcraft and Dr. Al-Rajabi? Like, you guys, a duo coming in and talking to her together?
We can do that. We try to frequently.
That's really cool.
On this past Friday,
Yeah.
Dr. Al-Rajabi and I did that 2 or 3 times together. If we can time our clinics right, and we can make the patients kind of connect at the exact same time, we'll just get in there and try to do everything at the exact same time. Because so much of Dr. Al-Rajabi's conversation is just going to be repeated by my conversation, and it's best if she can just have it once with us, simplify things for her, and then get her continuing on her therapy.
And Dr. Al-Rajabi, is that common? Dr. Ashcraft is talking about the panel that went over Tiffany's case, and you guys are going in together. That must feel really good as doctors to know that you've got this whole team working on one case, bouncing ideas off each other.
Yeah, it's a wonderful resource. Honestly, we have 4 GI oncologists and 3 colorectal surgeons and hepatobiliary surgeons and radiologists and pathologists and geneticists joining our group. It's a really big group, and we know for a fact that multidisciplinary approaches to complicated cancers like rectal cancer always have better outcomes. So we're very fortunate to have a great group that's really specialized in unique, patients like Tiffany that really give us the best outcome and give us all of the perspectives about the cancer and the best way to treat it with the least downside side effects and toxicities.
Tiffany, that must have been a huge comfort at one of the most scary times of your life.
Yes, I will say, it was so nice when they did come together in the same room, and like they said, even when they weren't in the same room at the same time, I always felt like everyone was on the same page, and I think that was a huge comfort and a huge reassurance just to know that, all your doctors, even though they're kind of dealing with different parts of your treatment, that you're getting the same answers from everyone. It's just very reassuring.
When it comes to feeling reassured, one of the things that you've said helps you get through this journey was this incredible support system outside the health system as well that rallied around you. In fact, you shared a clip with us of your neighbors that I'd love to share with our viewers. So whose idea was the Christmas Carol?
I still can't even watch it without crying. It was one of my good friends, Megan. Her husband works at KU too, and she's kind of the one that got me hooked up with the medical team. So she just knew how much I loved Christmas and loved, getting out with my kids during the holidays and doing different things. And she knew I was pretty limited in doing those things that year. So she just kind of brought Christmas to us, which was amazing. It gave, my kids a special memory during, a hard time for them. And yeah.
These pictures are hard for any of us to look at without crying. I can't imagine what that felt like for you. You had so much support. When it comes to other ways that you saw it and felt it, what did that do for your body as well as your spirit?
Oh my gosh, it was huge. You know, I have an amazing community, amazing neighbors, friends, family, and they all rallied around what was going on with our family. They were great to my kids, and you know, from nurses at the treatment center to my kids' teachers and neighbors and friends. There were meal trains and groceries and flowers and texts and phone calls. I mean, the list goes on. I'm probably leaving so much stuff out, but yes, just their support and knowing that in a diagnosis that can feel very lonely and very isolating, they helped me realize that I wasn't truly in it alone.
You were going through so much, and unfortunately, you were about to be thrown one more hurdle because you were just almost ready for surgery, and then you catch COVID, which must have been like a gut punch. So I want to bring in Dr. Ashcraft because you have to make a decision then. Do we go on with the surgery? Do we postpone the surgery? How do you make that decision?
It's tricky with rectal cancers. With rectal cancers like Tiffany had, there's this sweet spot after we finish what we call neoadjuvant treatment, which is the radiation and the chemotherapy before surgery. We like to operate 8 to 12 weeks, somewhere in there. We have this window that we like to operate in. And so it really balances into what the symptoms of the patient are like. If there's severe symptoms, if they're hospitalized, high oxygen, needing a lot of support, we unfortunately are going to have to delay that surgery and probably push outside that window that we like to operate in. If a patient has mostly asymptomatic or mild symptoms, then hopefully we have that 4-week window we can play in. If we diagnose it early, then we push them towards the end of the 4-week window and try to get them into surgery right then. So we have a little bit of wiggle room that we can play with, and that's what we did with Tiffany, is we just played with the wiggle room a little bit to where we still got her in that perfect window. So
thank goodness. When it comes to the surgery, there was something interesting that I was reading when you shared a bit about her health journey, which is the ostomy. Tiffany's first surgery required that. First of all, can you explain, and am I saying it right, ostomy?
Oh, yeah.
What is an ostomy?
Tiffany knows. So an ostomy is where we bring your intestines to the skin. When a patient has, especially in rectal cancer, after Dr. Al-Rajabi's wonderful chemotherapy and Dr. Hoover, in this case, his wonderful radiation that helps us be able to get these tumors out, because the first attack is with radiation and chemotherapy to shrink the tumor. Then we can go in and cut the tumor out. When we have that completed, the tissue doesn't like to heal very well. And so what we do is we kind of go upstream from that and bring the intestines out to the skin. And that way you have to wear an appliance or a bag on your underneath your clothing on your skin. And so everything you eat will come into that. It's not ideal. It was not fun for her. I know it wasn't. I'm sorry I had to put her through it. But it did give that connection, that what we call the anastomosis. It gave it a chance to heal. And we had a much better outcome afterwards.
When you say you bring the intestine out to the skin, you mean you bring it outside the body? What do you mean by that?
Literally, you take a loop of intestines, make an incision in the skin, bring it out, and actually open the intestines and sew it around the edges to the skin to where you can actually see inside their intestines on 2 holes.
Oh, wow. So, Tiffany, you're nodding your head, and that must have been so weird to have and so surreal.
I mean, it's kind of mixed emotions, you know? I think I was so relieved after that first surgery, just because I felt like, you know, the tumor was gone, and I was relieved that, you know, that part of the journey was over. But yes, it was a whole new world. You know, people live with them for years and years, though. And, you know, you can have a normal life with an ostomy. It's not the end of the world. It's not ideal, but it definitely was a part of what saved my life. So, you know, can't hate on it.
How do you shower when you have an ostomy?
Tiffany's the expert, but the way
how do you go through your day? Are you it must be you're so afraid to bump against something or touch it.
I mean, the adhesive on the appliance that you put on your skin is very strong. You can shower like normal. It really, it's scary. It's different. It feels weird, you know, talking about, you know, stool and poop. It's not something we usually have is a big part of what we talk about during the day, but, you know, you are stooling into a bag that's attached to your stomach. So it's different, but I mean, I didn't have it for that long, 10 weeks, 12 weeks, and it was, it was a learning curve, but it wasn't as terrible as I thought it was going to be. So
I think that double thumbs up from Dr. Ashcraft. I think it's so important, something you said. You said it's weird to talk about or hard to talk about stool and poop, for lack of a better word, but that's what gets us in trouble. That's why we need to have these conversations, because it's saving lives to have conversations like this and have you share your journey, Tiffany, and have the doctors come out. We've got to have these conversations. It's part of the body, and we've got a huge problem with people under 50 having more cases of colorectal cancer. Another aspect of this is family history, and Dr. Al-Rajabi, sometimes there is a hereditary side. How does someone know if they're predisposed to cancer?
So anytime you have a first-degree relative, that increases your risk for colon cancer. So patients that do know of a family history and have persistent symptoms, those are the number one top patients that really need to be evaluated. Fortunately, family history only accounts for about 15% of all colon cancers. But once you have one first-degree relative, like your mom, dad, or brother or sister, then it increases your risk. If you have two first-degree relatives, it goes up even further. So it's very important to know your family history and to bring that up with your physician. Especially, with family history, you'll definitely see younger and younger patients being diagnosed.
Tiffany, did you know if you had a family history of this?
Well, I did have a family history. Unfortunately, my family history at the time that I was giving to my primary care doctor wasn't as accurate as I thought it was. I had a grandfather that had colon cancer early, like 35, but I had no idea about that. My mom kind of mentioned that after. He didn't go through treatment. It was just able to be locally removed. So it wasn't like a big deal when she was a kid. So she didn't really remember it until kind of all this came up. And then my maternal grandmother had uterine cancer, which was kind of under the umbrella of, I was later diagnosed with Lynch syndrome, which is the genetic component of my particular cancer.
So does that mean, Tiffany, your children will be screened earlier for this? Are there things you've been told you can ask for?
They will when they, there's not much they can do right now. So we'll wait until they're adults, till they're 18, and then they will definitely be screened.
On a bright note, you've also shared some video with us of you on the field, because you were part of the NFL's Crucial Catch Awareness campaign, and at Arrowhead Stadium, you were on the field. This must have been pretty amazing. I would love to know about all the different celebrities and people that you were able to meet.
Yes, it was a very fun experience.
Wow, look at that.
So we did, Dr. Ashcraft and I did the halftime show at this year's Crucial Catch game. They did a special halftime. We were on the field with different screenable cancer survivors. And
you're there with Andy Reid.
Chris Jones. Yeah, earlier in the season, we were able to go to the training facility and have a lunch and meet some of the Chiefs players, and yes, it was a very cool experience.
Casey Wolf, that must have been awesome.
Yeah.
Dr. Ashcraft, you were out there too. Super cool.
Yeah, she and I got to share that experience out on the field. It was pretty awesome. Unfortunately, a rowdy game, but still a fun time.
Yeah, that was a rowdy game. That must have been really neat. You also shared some family photos with us, Tiffany, that are beautiful. Tell us who we're seeing here.
So this is my husband, Vince, and my 3 kids, Sophia, Dansby, and Sebastian. Obviously, they were a huge part of my recovery and journey, and they're obviously my reason. They were the ones that kept me going, and there's a story with my middle, that one, Dansby. He loves to ask what was your favorite thing questions. So, at dinner it'll be, what was your favorite part of your day? And during treatment, he asked me, what's your favorite part of having cancer? Oh. And kind of took me aback for a second, but it didn't take long for me to think, you know what, my favorite part of having cancer is having a front row seat to seeing the best of people, the best in my doctors, that, you know, they're there to help and they were there for me, the best of my friends and community, that they reached out and helped so much. I mean, my kids really did get a unique opportunity to see how to be there for people, how to be a good friend. So that for those things, I am thankful. So if you need to know what my favorite part of cancer was, that's what it was.
What a beautiful way to look at it. That your child is very wise, right, out of the mouths of babes. We have so many community questions and comments right now. We're going to get to those in a minute. We'll answer all your questions, but first we want to check in with Dr. Dana Hawkinson, Medical Director of Infection Prevention and Control, for our COVID count update. Good morning, Dr. Hawkinson.
Let's not delay. We need Dr. Ashcraft to answer some more questions for us. So it's very helpful. So right now in the COVID count, 52 total cases, but 24 active, 2 in the ICU and 1 on the ventilator. So just kind of hopefully ticking down a little bit, especially not going back to those mid-30s that we saw a couple times last week.
I want to ask you about last week. We saw some progress on the first ever RSV vaccines for adults. The FDA still needs to give approval, its final approval, but an advisory committee gave the thumbs up to 2 different shots. So, Dr. Hawkinson, my question to you is, should we expect to see these new RSV shots available this coming fall?
You know, I think we expect that, and when those companies first released some of their data, they definitely said it wouldn't be for this year. So we are hoping and believing that it will be for next fall. But also remember, there is a pediatric vaccine that also may be helping, and that's a vaccine that is actually given to mothers, so mothers can boost their immunity, and then that immunity, specifically the antibodies, are transferred to baby. So when baby's born, they do have protection. So we are looking for more information and possible approval for that one as well.
So how do you decide if you need one? Is this something you proactively ask your doctor for or about?
Yeah, most likely there are going to be criteria such as age is probably going to be the biggest one. It's probably either going to be over 60 or over 65. And then, of course, just talking to your physician about that. But that is probably going to be the biggest criteria. Now, maybe moving forward, there may be studies in those that are younger than that age but immune suppressed and may see benefit from that as well. But we need to wait for the data and the ultimate recommendations on that also.
Thank you, Dr. Hawkinson. I want to ask if we have any reporter questions today. Any reporters on the line? Okay, well, we have plenty of viewer questions, so let's get to our community questions. On Facebook, Ann Sullentrop writes, should we start getting colonoscopies at younger ages routinely? Dr. Ashcraft.
So the national guidelines in the past 2 years have went from screening at age 50, brought it down to age 45. That's the jump they made. I think a lot of us wish they would have went lower, but that's in terms of screening routine, no symptoms, no signs, no nothing, has dropped down to 45. The key thing to remember is what Dr. Awarjabi was talking about earlier. Any bleeding, any change in bowel habits, any of the symptoms that last more than 2 weeks in terms of your bowel habits, weight loss, fatigue, you should be seen by your medical professional and then be evaluated. Colonoscopies are not that bad. They're not that hard. The prep is not as bad as what it used to be even, and it's tolerated really well. It's a very simple, straightforward procedure, so we highly recommend you get it.
So if you're getting bloating, like Tiffany said she was feeling bloated and tired, can you ask your doctor to get you in for a colonoscopy?
I think you should see your physician and ask what it could be, especially when, even though bloating's a not very non-specific GI complaint, it still is a GI complaint.
Sure. And
so put that together with, once she keyed in on the bleeding, that was probably a big shoe-in that she needed a scope. And so I think just the bloating and the fatigue probably wouldn't lead down the road, but it might lead to labs, which would then lead to further testing and a colonoscopy.
Dr. Awarjabi, Juan Carlos Reyes has a question. He wants to know, are there preventable protocols of colorectal cancer? So things you can do to prevent it, any protocol?
So colonoscopies, the reason we see a drop in cases above the age of 50 is because we've initiated colonoscopies, and that basically identifies colon cancers at early stages of life, or early stages, and makes them more curable. But it also addresses any pre-malignant cancer polyps that could be addressed with colonoscopies. So hopefully, with lowering the age limit for colonoscopies, we could potentially prevent a lot of this. One thing I'd like to add is if you have a family member that was diagnosed with colon cancer, you need, and it's a first-degree relative, you need to consider getting your colonoscopy 10 years before your family member was diagnosed. So it doesn't, the 45 rule doesn't really pertain to patients that have higher risks, just like Dr. Ashcraft said. So if you have a family member and a strong family history and you're having, even if you're not having symptoms, usually we recommend if a mother or father were diagnosed, all their kids should be scoped 10 years before they were diagnosed.
Question from Yen Liang, and this is interesting. Yen Liang writes, in the past, people often use salt or sugar to prevent food from spoiling. Can that preserved food be considered as processed food? That's an interesting question. I mean, it's never good to have a lot of salt or sugar, but in the past, and he writes this too, people did that without having this spike in colon cancer. As a doctor, I know you're not a nutritionist, but you...
No, and that was going to be the thing I keyed on. We've been salting foods and curing foods for hundreds of years now, and we haven't seen the spike that we're seeing now. So I think it has to be something other than that.
Right.
But much like you said, high salt diet is not good either. So
yeah, with that, usually we would have seen more stomach cancer. So in the past, when we didn't have refrigeration in the United States, stomach cancer was one of the leading causes of death before we had refrigeration. So once we had refrigerators and we didn't have to salt or cure our meats, that number has fortunately gone down.
Interesting. As I bring our entire panel back in for some final thoughts, Tiffany, I want to start with you, but I want to read a really nice message from viewer Ann. She writes, what an absolutely brave young woman for what she went through and for sharing about it.
Well, that's a sweet message. Yeah, I think I wanted to be here today to share my story because, you know, like they said, this rise in younger patients with colorectal cancer combined with it's not something that people want to talk about or feel awkward talking about. So I thought it was important just to share my story and to for people to know that colorectal cancer doesn't look like, you know, an old guy that eats a lot of red meat and smokes all the time. You know, it can look like a young person. I was hiking and running up to, you know, the week before my diagnosis. So you just have to make sure you're listening to your body and you're pushing if you feel like something's wrong. It probably is. And also, you know, I wouldn't want to miss an opportunity to thank Dr. Al-Rajabi and Dr. Ashcraft. Obviously, you know, they saved my life. They are amazing. They still are so supportive and encouraging and have been here for me every step of the way. So thank you to both of you. You know, there's no thank you in the world big enough. So.
Aw, that's wonderful. Dr. Al-Rajabi, would you like to add on to anything that you would love viewers to know or love Tiffany to know?
Well, Tiffany, it's always been it's always a pleasure taking care of you in clinic, and I know you definitely are a warrior, like everyone says. You went through a very unique regimen that we devised for you, and tolerated that like a champ. And you know, you really did all the work. We were just there to cheer you on, but it really was you. And this is really important, I think, to spread the word so we could save more lives in our community.
Dr. Ashcraft?
I would echo what Dr. Al-Rajabi said. You know, so much of treating cancer and so much of getting through cancer is the patient. And Tiffany went into this headstrong. Even though she had that first bump in the road, which might have set many patients aside, she kept pushing through, and she got through it. And when she had 2 surgeries, and she pushed through those 2, and those are hard, hard on her, hard on her family, But she pushed through it. She was very strong, and so I'm very proud of her. And she's on the other side now, and now we're just watching her and making sure she stays healthy. As for the overall theme, March is Colon Cancer Awareness Month, and the idea is to just prevent cancer. And the one way we have to prevent this disease right now is a colonoscopy. Don't be afraid to get it. If you're of age or if you're concerned about symptoms or you have a family history, go get it.
Dr. Hawkinson?
Yeah, I think that's right. I think we continue to focus on prevention because it is so easy, but I know we have to take time to do that. But there are so many things we can do for prevention. Screening, colonoscopies, obviously we've heard about other screening tests. Please talk and get with your medical teams to assess those needs. And also, of course, prevention is vaccines, and we've heard a lot about that as well. So I think it's important to continue to endorse prevention. There are many ways to do that. It just starts with being able to talk with your medical teams or your pharmacists, at those other pharmacies if we're talking about vaccines and all of those things. So prevention is always better.
Thank you so much to all of our guests today. Tiffany, you are amazing. Thank you for coming on the program. This will save lives, sharing your journey. And thank you so much to our viewers today for being here with us and joining the conversation. We will see you right back here tomorrow morning.
Coming up tomorrow on the Morning Medical Update. It's crunch time in college basketball. What does it take to keep the national champs healthy? I'm Jessica Lovell on the next Morning Medical Update. Meet the minds behind Kansas Team Health, a unique partnership putting athletes closer to medical experts. Tuesday at 8.
Subscribe to our Morning Medical Update and Open Mics with Dr. Stites podcast. Now everywhere podcasts are available.